Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. I'm Louis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in the meeting control toolbar. To toggle the meeting control toolbar permanently on, press the Alt key once and then press the Alt key a second time. As always in our sessions, only the speakers will have audio. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-8669-900-9128 or 1-646-558-8656. And the webinar ID would be 864-8854-2838. I want to remind everybody that this webinar is being recorded and can be accessed on the adapresentations.org website in the archive section next week. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990, the ADA. Upcoming sessions are available at adapresentations.org under the Schedule tab, and then follow to Healthcare. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific time. By being here, you are on the list to receive notices for future webinars in this series. The notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along on the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the Healthcare Schedule webpage of adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform, and the speakers and I will address them at the end of the session, so feel free to submit them as they come to your mind during the presentation. To submit those questions, you type in the chat area text box, or if you are using keystrokes, press Alt-H and enter that text in the chat area. If you are listening by phone and not logged into the webinar, you may ask your questions by emailing them to adatech@adapacific.org. That's ADATECH@adapacific.org. If you experience any technical difficulties during the webinar, you can send a private chat message to the host by typing in the chat window. Type your comment in the text box and enter. And if you can also email us at adatech@adapacific.org, or you can call us at 510-285-5600. Today's ADA ADA National Network learning session is titled How Crisis Standards of Care Can, let's go back. How crisis standards of care can ensure equity for people with disabilities during times of crisis. As hospitals around the country are increasingly stretched to their limit by increasing numbers of patients presenting critically ill with COVID-19, many find themselves unable to provide the usual standard of care for their patients. In these situations, healthcare institutions may be required to shift to operating under so-called crisis standards of care, or CSC. These guidelines can help ensure equitable distribution of limited resources during times of crisis. However, without careful and specific emphasis on protecting marginalized and minoritized communities, they may also exacerbate existing inequities in care. This session will discuss the ways in which CSCs can be written and implemented in a way that safeguards equity for people with disabilities, as well as members of racial and ethnic minority communities. Today's speakers are Dr. Emily Cleveland Manchanda. She's an assistant professor of emergency medicine at the Boston University School of Medicine and works clinically in the emergency department at Boston Medical Center. As the director for equity initiatives within the department, her research and advocacy work focuses on mitigating the effects of racism and other forms of discrimination in clinical care. She is passionate about health equity and developing strategies to support equitable care for patients of all races, ethnicities, genders, and abilities. Colin Killick is the executive director of the Disability Policy Consortium, an independent research, healthcare ombudsman, and civil rights advocacy organization in Greater Boston, run by and for people with disabilities. Colin serves on the advisory committee to the Massachusetts Health Policy Commission and the Massachusetts Department of Public Health's COVID-19 Health Equity Task Force. After co-leading the Massachusetts disability community's successful efforts to repeal the state's first and second versions of the COVID-19 crisis standards of care, he served on the committee that drafted the third and final version of those standards. He has multiple disabilities himself and believes strongly in the necessity of intersectional advocacy against the intertwined forces of racism, homophobia, misogyny, and ableism. I will now turn it over to you, Emily and Colin.
Wonderful. Thank you so much for that kind introduction. I think with that bit of background, we can go ahead and jump right in to our presentation. So as was mentioned, we are going to be discussing how crisis standards of care can ensure equity for people with disabilities. I'm going to start and then we'll turn it over to Colin after a bit of a closer look at what crisis standards of care are. Next slide. So we have no financial relationships that we aim to disclose that relate to this presentation. Next slide. And here's the outline for our presentation. We'll first consider what crisis standards of care are and why we need them. We'll dig a little bit deeper into how CSC actually work, and then think a bit about how they can perpetuate inequities within the healthcare system. We'll then talk about best practices and next steps with the consideration for what we can do, not just during the COVID pandemic, but beyond to ensure equity during other times of scarcity. And we'll leave time at the end, of course, for questions and discussion. Next slide. And so our objectives are that by the end of this session, each of you would be able to explain why we need crisis standards of care, and identify 3 ways in which the existing crisis standards that are in place in many states across the country may discriminate against marginalized populations. We also hope that you will be able to identify 3 ways in which we can ensure greater equity in CSC guided decisions by the time we finish this session today. Next slide. So what are they? Essentially, crisis standards of care create structure and rules to guide ethically challenging decisions about rationing scarce resources. As the H1N1 virus spread way back in 2009, the HHS Assistant Secretary for Preparedness and Response, or ASPR, asked that the Institute of Medicine develop guidelines for resource allocation in times of scarcity. The resulting report led to a series of recommendations and regional workshops for developing crisis standards of care. That IOM report and the workshops identified a number of key ethical principles on which crisis standards should be developed. And those include fairness, duty to care, duty to steward resources, transparency, consistency, proportionality, and accountability. And those principles are meant to be considered when developing guidelines for how specific resources can be allocated during any time of scarcity. Crisis standards of care are meant to be flexible so that they can be applied during any kind of crisis. So, as we've discussed, obviously, in this context, during a viral respiratory pandemic, but also during a natural disaster or a mass casualty event, such as a terrorist attack. Essentially, crisis standards of care enable healthcare teams to shift from a lens of duty to care for the individual patient to caring for the broader population when we don't have our usual resources available. Next slide. So to think about why we need them, I'll give you a couple of examples. You can imagine a situation, or if you're a clinician like me, it's easy to imagine a situation in which you might have 4 patients who come into the hospital, into the emergency department, very, very ill, and need to be put on a ventilator. They need to have a breathing tube put in. However, you might learn as multiple things are happening across the emergency department at the same time that there are actually only 2 real ICU level ventilators that are left in the hospital. Alternatively, if you can click, you might imagine that there are 3 patients within the ICU who need dialysis. They all need dialysis relatively emergently. However, it may be the case during times of crisis that there's only one dialysis nurse who's available. You can click, and he may be already have worked for a full shift already. So rationing of care in many parts of the United States is hidden from the view of the treating physician. So hidden from the emergency department physician who's deciding about putting in a breathing tube, or hidden from the physician in the ICU who's thinking about who gets dialysis first. Instead, what we often face is access to care being limited by economic status or insurance or proximity to healthcare facilities. These upstream social determinants of health that really ration based on access and are the reason that we have and are undermined and sort of supported by inequitably distributed health resources, which then lead to inequitably distributed health risks and disease. As we've seen this year, however, resources in even the most affluent hospital systems in Manhattan, for example, can become severely limited during times of crisis, such that a different system is needed for prioritizing patients so that we can safely and equitably determine who should be prioritized over someone else. Without crisis standards of care, we remain in our usual state of first come, first served healthcare, or perhaps even worse, we may end up relying on treating clinicians to make determinations about who should receive priority. Decision making at this micro level limits opportunities to leverage resources across institutions or to compare patient needs across a facility or a region. So you might imagine, if you can go to the next one, in this situation, there might be another institution down the street or just across the state line, for example, that has extra ventilators that they don't need in that particular moment or that particular day, that they could lend to this institution to prevent 2 of those patients who are on transport ventilators from having an adverse outcome. They may also have additional staff who they could send across town to work as a dialysis nurse in that other ICU if they are not themselves in the same position of scarcity. So next slide. Without crisis standards of care or other guidelines, the clinicians who are caring for patients, you can click there, may be left to make these decisions on their own. And that will almost inevitably lead to moral injury on the part of that treating clinician. The decision about who should live or who should die is not one that we are trained to make, particularly in the moment. Bias about perceived quality of life and whose life is worth saving can also easily enter into those decision-making processes, even if unconsciously. And at the same time, you can click, without published and publicly available guidance, resource allocation decisions made by hospitals or clinicians may create understandable perceptions of injustice among families of patients who are deprioritized from receiving those resources. So crisis standards of care should be developed and made public before a crisis in order to standardize decision making. And they should also reflect the ethical principles of the community in which they're going to be used. You can click to the next slide. Unfortunately, however, we know that not all states have crisis standards of care that have been published. And in fact, as of this summer, only 39 states in the country had some version of a CSC document. 23 of those, in fact, were actually published in 2020 amidst the COVID pandemic. So this map shows dark blue states, which have crisis standards of care guidelines that provide specific instructions for how to prioritize patients for resource allocation. Those lighter blue states have a more general guideline, and those purple states were ones that were in development over the summer and presumably by now have been finalized. Apologize, the map is not completely up to date. As far as we know, only Arizona officially enacted crisis standards of care at some point during the pandemic, although we know that there were rationing decisions made in California and in New York at various points over the course of the past year. It's also not clear the extent to which the guidelines in Arizona or anywhere else were used to guide the allocation of resources, or which resources were allocated using their CSC frameworks. All right, so we'll go to the next slide and turn to a consideration of how crisis standards of care, these guidelines, actually work. Firstly, it's important to recognize that the prioritization scoring or allocation decisions under crisis standards of care are made by a triage officer who should not be the treating physician or someone who has a direct doctor-patient relationship with the individuals who are under their care. So that's just an important consideration. You have an external, not necessarily external to the institution, but an additional person who doesn't have that individual duty to care for the patient, but rather has more of a system level lens and view of the overall needs of the population that they're caring for. The structure for crisis standards involve 4 phases, really. The sort of first phase determines who gets in. So the exclusion criteria that are incorporated into many crisis standards of care are one thing that we'll consider. Next, the crisis standards focus on the acuity of a patient's condition, how sick that person is in that given moment. Most also consider some version of long-term benefit or longer-term benefit before resources are then allocated. That's step 3 here. And then there is also a provision for the reconsideration of resource allocation over time, which we'll discuss in the coming slides. All right, so we can go to the next one. So for exclusion criteria, you can click. This is really a question of who's considered eligible for resources in the first place. So many states have exclusion criteria that limit consideration for access to intensive care or other limited resources during times of scarcity under their crisis standards. There's wide variability here, from broad statements, for example, in Washington, that any significant underlying disease process that predicts poor short-term survival was a part of their exclusion criteria. Alternatively, some states have very highly specific metrics, like in Kansas, where they had said severe burns on a patient with any 2 of the following conditions: age greater than 60, 40% total body surface area of their body affected, or inhalation injuries should be excluded from consideration. And those are generally things that are based on a very low likelihood of survival, even if resources were available. Some states, like New York, have chosen to omit broad exclusion criteria, with the exception of patients who would not typically be allocated resources even during normal times. So for example, a patient who gets brought into the emergency department and has a very prolonged course of CPR and all of the other resuscitation efforts, but who has shown no signs of recovery. In those cases, we typically terminate efforts because we feel that they're futile. All right, so once we move beyond exclusion criteria, we'll go to acuity. The first real step of prioritizing patients under crisis standards is a consideration of who needs that scarce resource the most. And all of the crisis standards in the US incorporate the use of what's meant to be an objective scoring system. And this is called the Sequential Organ Failure Assessment, or SOFA score, or the modified SOFA, which just uses slightly different clinical data. The score is then translated into a priority category, usually 1 through 4, based on the patient's prognosis for surviving that acute illness that they present with. SOFA incorporates data from the patient's vital signs, their heart rate, their breathing, that type of thing, as well as their lab results and their exam, which is based on the Glasgow Coma Scale, or GCS, and we'll talk about that in a bit. SOFA is validated in predicting mortality at the population level among patients who are sick or critically ill with an infectious process, so patients who have sepsis, but it's not a triage tool, and it may not actually be as good at predicting the likelihood of survival from a viral respiratory illness like COVID. But for the purposes of prioritization under crisis standards of care, a patient with a higher SOFA score receives a lower priority because they have a poorer predicted survival. So the next step in crisis standards of care is consideration in most states of the likelihood of benefit. So most crisis standards of care provide an additional adjustment to a patient's priority score based on predictions of longer-term survival. By considering the patient's other health conditions, the triage officer or team is asked to predict the likely long-term benefit. That's usually done by decreasing the priority of patients who are seen to be less likely to survive more than another 5 years, even if they were to make it through that acute illness, and by further deprioritizing patients who have such serious medical conditions that they're likely to die within the next year. So each patient's priority score is then calculated. You can click, and that generates a priority category. And so resources are then allocated according to that priority tier. It may be that additional tiebreakers end up being needed in order to allocate resources even within a given priority. And again, there's lots of variability here across states. I won't get into specific examples, but some states say that with all other factors being equal, triage teams can make decisions based on age or pregnancy, or an individual's role as an essential worker with increased assumption of personal risk. Others rely solely on a lottery system for allocating resources among patients within a single priority tier. And we'll talk a little bit more about those tiebreaker criteria later in the talk. Most crisis standards of care also explicitly state that resource allocation should be reconsidered at specific time intervals. So you can click. And for example, this may be done daily to determine whether resources should be reallocated within the cohort of patients who need them. So this helps to get around some of the problems inherent in a first come, first serve system, whereby you might have patients who would actually benefit more from a resource who arrive later in the process or in the pandemic. Reallocation would involve withdrawing care from lower priority patients in favor of allocating them to someone who is more likely to benefit at that given time point. All right, next slide. So I just want to pause for a moment because you just had a lot of information thrown at you in the past 10 or so minutes. And for some people, this may feel really abstract or theoretical, while for others who might have been put in the position of making some of these really difficult decisions or seeing decisions like this being made for their friends or family, it may be a little bit overwhelming to have thoughts of these really challenging issues brought up over a webinar. The decisions about crisis standards of care are really some of the biggest ones that doctors and healthcare professionals face, both in terms of our caregiving and just as humans. And so I want to just pause to acknowledge that these are really challenging ethical and moral issues. And while we try to do the best we can, they're always very, very difficult conversations to have. So from here, I do want to turn to thinking about how equity can be incorporated into crisis standards of care and ensuring that everyone has access to equal resources, even during times of crisis. All right, so we can go to the next slide. So we'll think now about how crisis standards of care may perpetuate inequity. We'll do this through asking 3 questions. The first of these is, where are crisis standards of care most likely to be needed? So I would argue that in my experience, poorly resourced facilities may become more easily overwhelmed by a surge of patients during a pandemic. This is in part because of the differences in the ease with which facilities can control availability of inpatient beds in anticipation of a large influx of patients. So big, wealthy private medical centers profit from filling a high proportion of their inpatient beds with patients who are there for elective surgeries. These can be canceled if you know that there's a big wave of patients coming, either from a mass casualty event or from a COVID pandemic. Is something that's a little bit more foreseeable. Safety net hospitals, however, like where I work, more commonly fill the vast majority of their inpatient beds with unplanned admissions, for example, through the emergency department. So our ability to flex our inpatient space in anticipation of a surge really is very different from that of private medical centers that rely more on elective procedures to fund their institution. There are also differences in the ways in which facilities are compensated. And we saw that some of the relief aid that was delivered to institutions differed significantly between safety net hospitals, which received less federal support, and some of the private centers, which leveraged more of their connections and some of their agreements to receive more support than even those places that were hardest hit. We'll go to the next slide. So the second question of equity is between patients rather than between institutions. So who's likely to be sicker on arrival? We know that among patients who acquire COVID, people with chronic comorbid conditions like COPD, obesity, hypertension, diabetes, or renal disease are more likely to require intensive care than people without those conditions. Because those same conditions are significantly more prevalent among Black, Latinx, Native American, disabled, and other marginalized populations in the US, on the whole, these groups are more likely to become severely ill than white people who don't have disabilities. This may mean that at the population level, people from marginalized groups are, again, on the whole, more likely to have a higher SOFA score and thus end up being given a lower priority for resource allocation under crisis standards of care. You can click. Even the seemingly objective SOFA score may systematically discriminate against some groups unless we're careful. So for example, people with significant motor or speech disabilities may have a lower GCS score, a lower Glasgow Coma scale, which is incorporated into that SOFA score, if they're unable to follow motor commands or speak clearly, even when they're not sick and they're at their functional baseline. As Colin will discuss more, there were several successful lawsuits that were filed in the past year by disabilities rights groups based on these concerns, which led to CSC revisions in at least 6 states to ensure protections for people with disabilities. Next slide. And so the last question in terms of thinking about inequity and how crisis centers of care may inadvertently perpetuate them is important to think about with regard to who may or may not survive the next 5 years. So predictions of long-term benefit can be really problematic. Your typical 18-year-old will almost certainly have a greater life expectancy than an 88-year-old, no matter how healthy they are. But as the age gap between people competing for a scarce resource narrows, their underlying health conditions play an increasingly important role in determining who will be more likely to benefit from that resource in the longer term. The same life-limiting comorbid health conditions and social determinants of health that lead to Black, Latinx, and likely Native Americans becoming sicker than white Americans when they acquire COVID also reduces those individuals' life expectancies, independent of that acute illness. People with disabilities linked to chronic health conditions like ALS, cystic fibrosis, SMA, and those who require assistance with their activities of daily living may be perceived as having a lower likelihood of survival past 5 years, whether or not that's actually true. So crisis standards of care that ask triage teams to add penalty points for likely death within 5 years, for example, will deprioritize patients with chronic lung disease who require home oxygen, or people with chronic dialysis, both of which are disproportionately common among people with disabilities as well as among Black and Brown people in America. These crisis standards of care, therefore, can introduce systematic ability and race-based bias into their seemingly objective prioritization frameworks. All right, so next slide. What do we do about it? I'm going to make some specific recommendations about the actual crisis standards of care guidelines, which you can look through your state to see if they apply for your particular situation. And then I'll turn it over to Colin to discuss the bigger picture in terms of advocacy and legislative opportunities. Next slide. So we're going to talk about 6 ways in which crisis standards of care can safeguard equity. 1 relates to planning, 1 relates to access to resources, 3 are related to scoring mechanisms and a little bit more of the technical details of crisis standards of care, and then 1 final recommendation about tiebreaker decisions. I also just want to pause and take a moment to give credit to my colleagues within the Society of Academic Emergency Medicine and the Massachusetts Coalition for Health Equity, with whom I collaborated to develop these recommendations. And these are all included in a statement issued by SAEM last summer, and the reference to that is linked at the end of this presentation. So next slide. The first recommendation is for coordination. Pooling of resources between regional institutions has to be exhausted before crisis standards of care are enacted at any single facility. We saw this fail in New York last year, where providers at Elmhurst and Queens faced decisions that would have been unnecessary if patients were transferred to less affected hospitals in other boroughs. State departments of health and other coordinating bodies should ensure that coordination agreements are created ahead of time to allow for the procurement and sharing of resources, as well as for patient transfers between facilities. We saw this happen in Boston during the peak of our first surge back in April, and lives were saved as a result of transfers from patients out of my hospital and into other hospitals in the city who still had space despite the surge of patients. Particular emphasis needs to be placed on creating those agreements between well-resourced facilities and the safety net hospitals nearby, because as we've discussed, those safety net facilities may have a more limited ability to adapt in anticipation of a surge of ill patients. Having a national healthcare system through which we pooled our resources remains a pipe dream of mine, but explicit coordination for future public health crises should be created to allow and also to reward facilities and states for collaborating across their traditional borders. Next slide. So just a moment again, thinking about exclusion criteria, to just say that broad exclusion criteria that limit access to critical care resources, even during times of scarcity, should really be limited to avoid excluding wide segments of the population. For example, age cutoffs or use of subjective or vague exclusion criteria like dementia, which was listed as an exclusion criteria in an original crisis standard of care document for one of the states, may lead to relatively healthy individuals who might have a very reasonable chance of survival being categorically denied access to resources that have become scarce. This is also true for heterogeneous groups of patients, such as individuals with indolent malignancies or cancers, or patients who require dialysis, some of whom may have an excellent quality of life and many years of life left to live. If required, exclusion criteria in crisis standards of care should be limited to truly objective conditions for which a patient has an obvious and imminently dire prognosis. Again, things like unsurvivable traumatic injuries or ongoing CPR that has failed to resuscitate the patient. Okay, next slide. So we'll turn now to 3 recommendations for the technical aspects of crisis standards of care and how we allocate resources if we need to. So in the ideal world, we'd have disease-specific triage tools that would predict mortality for each of our patients, giving us a validated likelihood of survival based on their individual presentation. Unfortunately, we don't have that. As we've discussed, SOFA was not meant to be a triage tool. However, until we have improved tools and something that works better for COVID, SOFA may well be the most objective means of quantifying a patient's acute sickness. But as we'll discuss next, those tools have to be applied with consideration and even with adjustments because we understand that they are limited. Next slide. So crisis standards of care scoring systems must explicitly protect the rights of people with disabilities to have equal opportunity to access resources even when they become scarce. So hospital policies and procedures need to afford reasonable accommodations, both for support people during hospitalizations, even when we have changes in visitor policies, and for evaluation of patients under crisis standards. So patients who, like my son, have cerebral palsy may not be able to follow motor commands or communicate verbally, even when they're at their baseline. And scoring systems like SOFA, which incorporate GCS or other seemingly objective measures of function, must not give lower scores to people like him who have disabilities. And the Massachusetts Crisis Standards of Care, because of advocacy by Colin and others within the MCHE, now include language that explicitly provides accommodations for how we measure GCS among people with disabilities. And that language and those recommendations can be incorporated into local and other states' crisis standards guidelines. It's also important to think about how some of the other factors in our lives may influence our presentation and what gets measured in crisis standards. So if some measures within seemingly objective scoring systems track very closely with adverse social determinants of health, then we should also reconsider them and make some adjustments. So for example, the disproportionate burden of chronic kidney disease among Black and Brown people in the United States may lead to worse SOFA scores, since one measure of kidney function is included in SOFA. To adjust for this, some states, again, like Massachusetts, because of our advocacy, have capped the number of SOFA points that you can add to a patient's score if they have chronic kidney disease at baseline. This is still a colorblind policy. It's an adjustment for all patients, but at the population level, we would expect that this would provide a greater protection to people of color who, again, have greater burden of chronic kidney disease on the whole. All right, next slide. And this is my last recommendation for the actual technical crisis standards of care piece, which is really that crisis standards of care should only consider the likelihood of surviving the acute illness and not the number of life years or longer term benefit. Consideration of longer term mortality introduces systemic racism and discrimination against people with disabilities into the resource allocation process by biasing resource allocation against populations that have both a higher chronic, prevalence of chronic disease and shorter life expectancies on the whole. If two patients' degree of illness, their degree of need for that resource that's become limited or scarce is equal, then neither long-term survival, predicted life years yet to live, or age should be used to make allocation decisions. As we've discussed, the underlying medical conditions that track with disabilities or racial and ethnic health disparities will already have played a role in the patient's presentation, when they got there and how sick they are. And so those are already going to have contributed to the patient's relative priority under crisis standards of care. All right, we'll go to the next slide. It's my last recommendation. When a tiebreaker is needed to determine which patients within a given priority category should get a scarce resource, then we really would want to use a lottery. There are several groups that thought about how this might be done, and some have recommended using something like a weighted lottery, which might give additional priority, a little bit of an edge, to historically disadvantaged groups, for example, patients living in poverty, or individuals who bear a greater individual risk. So for example, healthcare workers, bus drivers, grocery clerks, or other frontline essential workers who are required to keep our society functioning even during times of crisis. There's a system that was developed at the University of Pittsburgh for allocating scarce medications like remdesivir, the antiviral medication that we can use to improve survival in COVID. And that provides an interesting example for how we might think about a weighted lottery. All right, next slide. So these 6 recommendations are really meant to help us think about how to improve existing crisis standards of care. And I'm now going to turn it over to Colin, who's going to walk us through some of the higher level ways in which these issues played out over the past year here in Massachusetts and beyond, and to talk about what we can do moving forward.
Great. Thank you so much, Emily. Folks can hear me? I'll take that as a yes unless something pops up in the chat. Okay, great. So yeah, as was said, my name is Colin Killick. I'm the Executive Director of Disability Policy Consortium. We're a civil rights advocacy organization in Massachusetts, run by and for people with disabilities, and we wound up leading the fight related to crisis standards of care here in Massachusetts. Next slide, please. So what this came down to really for us is, in order to work on this issue, you first have to understand what the actual question at stake here, right? Because it was tempting, I think, particularly for policymakers, to view this as something objective, right? As a utility maximization problem. It was a matter of finding the right formula, right? The right algorithm, the right point scoring system. And that because such measures were rational, were objective, because they involved numbers, that they were therefore objective, right? That this was a problem that could be solved, that there could be a correct answer to. And in fact, that's not true. And in fact, the technical nature of these standards, right? The fact that they involve these complicated scoring systems, I actually think made it in some ways more likely for adverse outcomes to occur because they obfuscated the actual question at stake. It's a profoundly moral question, a very simple question, and one that impacts people with disabilities, not just in this one area, but very broadly throughout essentially every aspect of our lives. And this is this question: whose lives do we value? And by we, I mean as we as a society, and by we, I mean specific people. Whose lives do you value? And do you believe that everyone's lives are equally valuable or not? Next slide. Because in fact, right, people with disabilities, the lives of people with disabilities are systemically devalued in our society in all kinds of areas, right? It shows up, for instance, in the fact that we still face massive discrimination in accessing housing, in accessing employment, in accessing education, right? Here in Massachusetts in 2021, it is still, there is still no requirement that an employee-only area of a business be accessible, right? There are academic studies by folks like Lisa Scher that show that if you mention a disability in your cover letter for a job, you're a third less likely to get an interview. But this isn't just confined to discrimination, right? It shows up in violence, right? A study by the Ruderman Foundation a number of years ago found that half of people killed by police have a disability. Half, despite people with disabilities making up 20% of the population. We're also highly overrepresented in cases of domestic violence, both intimate partner violence and violence by parents against children. And in fact, there's a longstanding and quite disturbing pattern of parents or caretakers who kill their disabled children being let off with very light sentences because of a perception that the life of that child was less worthwhile because of their disability, or that even that the parent was committing a so-called act of mercy by killing that child. In many states, people with certain disabilities are blocked from receiving organ donations, or disability status is a strike against someone in eligibility for organ donation. And that's not only disabilities that reduce someone's life expectancy, but also in many states, for instance, people with intellectual disabilities are barred from receiving organ donations because it's perceived that their lives are inherently of lower quality, right, are less worth living. And then this lastly comes to a metric which is widely used in health policy making. There's been a national push to use it in the pricing of prescription drugs, which it is in many other countries. And it's a metric I was taught. I went to public policy grad school at Harvard, and we were taught to use this metric as a good example of utilitarian policymaking. QALY, which stands for quality adjusted life year, pardon me, is a metric which is literally based on the presumption that the more disabled you are, the less your life is worth. It will put a value on your life. So for instance, it will say if you have what it defines as severe epilepsy, right? You have a QALY weight of 0.54, which is to say your life, according to this metric, is worth 54% of the life of someone with no disability at all. And a treatment that extends your life by 1 year would only get credit for 0.54 years of life extension. And this was kind of our entry into this. My organization has been fighting the use of that metric and others like it at both the statewide and national levels for a number of years. And we were told by policymakers again and again, you're imagining this, right? This metric is purely being used for price negotiations, right? For cost effectiveness analysis. No one actually believes that the lives of individuals with disabilities are less valuable than the lives of people without disabilities. No one is actually suggesting that people be denied care, denied life-saving care on the basis of their disabilities. And then the pandemic happened. Next slide, please. It hasn't switched. Oh, there we are. Yes. So as Emily mentioned, states adopted these crisis standards of care, and in many states, they adopted these categorical exclusion criteria, right? Saying that people with these specific disabilities would be denied ventilators, denied ICU admission, denied hospital treatment. And here are some of the more blatant examples. In the state of Alabama, they, among many other exclusions, said, if you have an intellectual or developmental disability, we will not provide you with a ventilator while crisis standards of care are active. Because in their judgment, the lives of people with intellectual and developmental disabilities are not of high enough quality for the use of a ventilator on them to be valuable. In Utah and Tennessee, if you had ALS, multiple sclerosis, spinal muscular atrophy, or cystic fibrosis, if crisis standards of care were in effect, you would not be admitted to the ICU at all, meaning if you required any level of ICU care, you would just be left to die. In Florida, they said anyone with a neurological disorder requiring, quote, lifelong assistance with most basic activities of daily living, an incredibly broad categorization that would capture many of my coworkers, many of my close friends, I'm sure some people on this call. If you fit that criteria and COVID-19 crisis standards of care were active, you would not be admitted to the hospital at all. You would be turned away at the hospital door if you had that condition, because your life was judged to not be worth saving. And in New York, while their policies generally were better than these, their crisis standards initially included a clause saying that if someone, not only would someone with a severe disability not be assigned a ventilator if they came into the hospital, but if they came in with their own personal ventilator, right, that they used for a chronic medical condition, that ventilator, if there was a shortage of ventilators, could be taken from them and reallocated to someone else whose life was judged to be more worth saving. Fortunately, in none of these states, things did not get to the point where these standards were actually used, in part because they were immediately and vociferously challenged by disability rights advocates. But for those sort of, folks like me living in blue states, right, who might be feeling smug at this moment, discrimination happened here too. It was just in subtle ways. Next slide. So more subtle forms of discrimination occurred in a couple of ways. So Emily was talking about these short-term metrics, right? The SOFA score, right, which was this metric that was used to assess short-term survivability. Not necessarily ideal for that, uncertain if it was actually valid in the case of COVID-19, but it was the best metric available. The trouble is that the SOFA score, and Emily could, as a physician, could speak to this better than I could, but it's designed to assess acute injury, right? You have a kind of implicit baseline that before the person sustained the condition from which they're presently suffering, in this case, before they contracted COVID, that their scores in these areas were quote unquote normal. And so when you have someone with an underlying disability, they, on some of these metrics, may give false impressions of low likelihood of survival that are in fact not accurate. And the Glasgow Coma Scale is a major example of this. And this is one of the things that we fairly quickly got overturned in Massachusetts. Because the Glasgow Coma Scale measures, among other things, neuromotor acuity. Now, I myself have a neuromotor disorder. I have the fine motor skills of your average 5-year-old. But that has nothing to do with my likelihood of survival. It's a developmental disorder. It has to do with, the connection between my brain and my hands. But if I were to be assessed using the Glasgow Coma Scale, I would show up as having reduced life expectancy, because that test is built on the presumption that before, say, the COVID infection, in this case, that the person's motor skills were normal. There's also this issue of kidney function tests, right, where in this case, it's less specifically that that poor kidney function indicates reduced chances of short-term survival, although it probably does overstate that. But in particular, that kidney disease, and in particular elevated levels of creatinine, which was the metric for kidney disease, are particularly high among people of color for reasons to do with environmental racism, basically. And so in Massachusetts, ultimately, the final standard we developed capped the amount of points that someone could lose from their short-term survival score based on the kidney function tests to make it less racially inequitable. But the bigger source of discrimination, the one we fought hard against, is this question around long-term survival, long-term benefit, right? And this question of what are we trying to save, right? What is the thing we are trying to maximize here, right? And is it lives, or is it life years, or is it even worse, quality adjusted life years? Because you will get very different answers there, depending on which of those you are doing. Next slide, please. Because this was the core of our argument. Saving lives is equitable. Saving life years is not. And what I mean by this is, here in Massachusetts, the first version of the standards that came out said, without limitation, our goal is to save life years, right? So you have two people in the hospital, their probability of short-term survival with a ventilator is the same, but person B is predicted to live 20 years, and person A is predicted to live 10 years, then that means by saving person B, you've saved twice as many life years. In fact, saving one person who is expected to live 20 years provides just as much value as saving 20 people who are each expected to live 1 year. And this, on the surface, sounds reasonable, right? It's the notion of save the most years of life. Except that inherently, right, all kinds of disabilities reduce people's long-term life expectancy, right? And this is a problem for a number of reasons. It's a problem because many of those conditions, diabetes, heart disease, cancer, asthma, kidney disease, etc., are predominant in people of color and low-income people. There's also simply the fact that, as we said earlier, people with disabilities are a massively marginalized group of people, are an intensely discriminated against group of people. A group of people whose studies consistently show get poor quality healthcare throughout their entire lives. And now, someone arriving in the hospital, having lived a life experiencing discrimination, having lived a life receiving poor quality healthcare, is being told that in no small part, thanks to the consequences of those things, their life is worth less and they are being sent to the back of the line for receiving care. So that's one major problem. The second major problem, as it turns out, is that physicians are, with no disrespect to physicians who do really difficult work under very difficult circumstances, not actually very good at predicting long-term life expectancy. It's an incredibly difficult thing to do. We all know in the disability community dozens of people who were told 5, 10, 15 years ago that they had 2 or fewer years to live, right? That happens all the time. And in fact, actually, what often happens is that the presence of disability is used as shorthand for reduced life expectancy. So even if these measures were perfectly accurate, they would be discriminatory, but it is compounded by the fact that they are not accurate. Next slide, please. So, as we laid out here, right, there are 2 major problems. One is the metrics are wildly inaccurate, and also that short life expectancy is often the result of discrimination, right? People have shorter life expectancy because they are not breathing clean air, because they are not drinking clean water, because they are exposed to lead, because they are exposed to violence, right? Because they live in a food desert, right? Or because they have a disability, which may in and of itself not do anything to shorten their life expectancy actually, but because it subjects them to poverty and discrimination and marginalization, they have a shorter life expectancy for those reasons. So our understanding is that in Massachusetts, if the first version of our crisis standards of care were used, which said without limitation, prioritized based on expected life years, thousands of people with disabilities would have been deprioritized, either because of the disability itself or because of their age. Our standards also said to use age as a tiebreaker, right? So whenever there was a tie, the older person would lose, which is fairly, it is age discrimination. That's blatantly what's going on. Next slide. So in response to this, the community fought back. We objected early, we objected often, we objected loudly. We got a lot of press coverage. We took every available opportunity to signal to the government and the public that this community had been disenfranchised. We pointed out that there were no disability representatives on the group that wrote the standards, that we were at no point consulted, that there was no effort made to understand our perspectives or to ensure that these metrics were not discriminating against our community. And importantly, we brought disability justice advocates and racial justice advocates together to advocate for these issues. We threatened legal action, and we threatened complaints to the Office of Civil Rights at the Federal Department of Health and Human Services. Ultimately, in Massachusetts, we didn't have to file suit because the Office of Civil Rights struck down other states' standards that used the same approach that we did. So they first repealed the first set of standards. They replaced it with one that said that capped the long-term life experience criteria at 5 years. They said, it will only kick in if you're predicted to have fewer than 5 years to live, which was a mild improvement, but is still highly discriminatory. We continued pushing. We again threatened to file a complaint. Finally, that standard was repealed. And on the third try, we got to the table. I and a couple of other disability rights advocates were appointed to the committee, and we ultimately succeeded in writing standards that were significantly friendlier to the disability community. Next slide, please. So our goal that we said the fair goal of crisis standards of care should be save the most lives. Count every life equally and save the most lives you can. And therefore, the thing to prioritize based on is likelihood of survival to discharge, right? That's the fair approach in our view, right? Is get the most people safely discharged from the hospital as you can, right? Now, this will still disadvantage people with disabilities, right? Because many disabilities, chronic conditions, will make it less likely that someone will survive, right? But we think it is fair. It is a non-discriminatory goal to save the most lives. We believe age should not be considered and comorbidity should not be considered, except in as much as survival to discharge is affected. We got, I would say, 85% of the way there in Massachusetts. We got the 5-year rule struck down. They did keep in a provision saying that you could consider whether someone was expected to have less than 1 year to live. We would have liked to see that it pared back to just survival to discharge, but going from 5 years to live to 1 year to live was still a significant improvement. Next slide. But the thing is, crisis standards of care are far from the only problem. And because of that, standards that are merely non-discriminatory are actually not sufficient. Because the harms of crisis standards of care were potentially massive, but thankfully largely theoretical, because as Emily mentioned, ultimately Arizona was the only state in which these standards were actually used in a formal way. But at the level of the individual facility or the individual doctor, there were real life-threatening instances of discrimination. There was a case in Texas that drew particular infamy, the case of a Black disabled college professor named Michael Hickson, whose doctor was caught on tape saying that it was not worthwhile to provide him with life-saving COVID care because he was paraplegic, because he was a wheelchair user. And ultimately that doctor, over the objections of Mr. Hickson's wife, was allowed by a court to terminate his care, and he died. In Oregon, it was found that despite crisis standards of care never being activated there was the systematic discrimination against people with disabilities, in particular pressuring people with disabilities, including those with, for instance, intellectual disabilities that did not directly impact their life expectancy. There were efforts to pressure them into signing do not resuscitate orders that said that would mean that they would not be provided with life-sustaining care like ventilators. This ultimately led to the state of Oregon passing legislation making it illegal for any doctor or medical facility to tell someone or their family or even suggest to them that they had to sign a do not resuscitate order or other advance directive as a condition of receiving care. And finally, as we speak, we're engaged in a pretty substantial fight around vaccine prioritization, right? People with disabilities not being given sufficient access to vaccines, right? And this is a thing that varies wildly. So for instance, in California or New Hampshire or New York or Georgia, right? All of them have made fairly broad allowances for people with disabilities that substantially increase their likelihood of dying if they contract COVID, conditions like cystic fibrosis, for example. Those folks in those states can get higher vaccine priority. But in a state like Massachusetts, none of that has been done. The only medical conditions that get you any increased priority are the ones on that first very narrow list of conditions from the CDC, which are almost all conditions that are incredibly common, right? So someone with cystic fibrosis, completely out of luck. And secondly, we know that ableism is quite rampant among physicians, and discriminatory beliefs about people with disabilities are quite common among physicians. There was a study just a couple of months ago by Lisa Iazzoni, Dr. Lisa Iazzoni, who's the head of the Mongan Institute for Health Policy at Mass General Hospital, which is affiliated with Harvard, which found that 80% of US physicians believed that people with disabilities have worse quality of life than non-disabled people, that only 40.7% of those physicians reported feeling very confident about their ability to provide the same quality of care to patients with disabilities as their other patients, and just 56.5% of them strongly agreed that they welcomed patients with disabilities into their practices. There was also a well-known study in 1994, but which has been upheld in subsequent studies in more recent years by Gerhardt et al., which found that among emergency room physicians specifically, only 18% of them believed that they would be glad to survive a spinal cord injury themselves. And a significant minority of them believed that less effort should be made to save someone's life if they would have a spinal cord injury. By comparison, 92% of people in the same study who actually had spinal cord injuries reported that their quality of life was good or better, right? So there's a huge disparity between the people who actually have the disabilities and the physicians in evaluating how high the quality of life of people with disabilities actually is. Next slide, please. So for all of these reasons, we believe that crisis standards of care need to not merely be non-discriminatory, they need to be anti-discriminatory, right? We believe that as the Massachusetts standards now do, they need to explicitly forbid the consideration of any quality of life standard, anything like qualities. It needs to explicitly state that not just that the state as a whole, but that individual hospitals or individual physicians cannot make decisions about who gets care based on a presumption about people having a higher or lower quality of life due to disability. We felt that there need to be institutionalized safeguards and an appeal process where folks can go to if they feel that their disability was improperly considered in determining whether they would receive life-saving care. We felt it was vital, and Massachusetts standards now reflect, that people with disabilities must maintain communication access, including having sign language interpreters available for deaf people and having family members or aides accompany people with disabilities people specifically who have intellectual disabilities or other communication disorders to ensure that their wishes be heard, even if hospitals are otherwise not allowing visitors in due to quarantines. And lastly, we would think that it's vital that there be mandatory bias training for physicians during these kinds of emergencies to explicitly counteract these potential sources of bias. Next slide. So this is my last slide here, and then I think we'll be going to questions. But the question then is, what now? What do we as advocates do? What should society as a whole do? So one thing is legislate before the next pandemic, before the next crisis, because while we all hope that something like this won't come around again, it is likely that someday we may well be back in the same position. So, and even between those things, discrimination at the individual provider level, at the facility level, is still rampant. So in Massachusetts, we've actually introduced a bill. It's called an Act Relative to Preventing Discrimination Against Persons with Disabilities in the Provision of Healthcare. It's docket number SD 1911 in the Massachusetts Senate, and I'm happy to send around information about this, which would, in Massachusetts, forbid the kind of discrimination that occurred in the first version of the crisis standards of care here, as well as discrimination at the level of the individual provider or facility. And that would also get to that second point, is forbid other forms of healthcare discrimination. We think we need to forbid the use of QALYs throughout the healthcare system, as was recommended by the National Council on Disability last year, and need to do additional work broadly to investigate and deter healthcare discrimination against people with disabilities. And finally, we think we need to start working now to address bias within the system. We need to work with physicians to shift the way that they view disability. And critically, we need to get more people with disabilities into the healthcare system and to get more people with disabilities becoming doctors to combat this form of systematic bias and ensure that when a person with a disability is ill, that it won't be going to the hospital that ultimately takes their life. Thank you so much.
All right, thank you so much, Emily and Colin. That was a tremendous presentation. And there were the references there for a moment, and now we'll, this is our chance, so do remember to submit your questions in the chat window, and we'll get to those in a moment. And I just want to follow up on one thing that Colin just described or talked about, and that was the Lisa Iazzoni study. Lisa did present about that on this webinar series last month. So if you want to hear more detail about her study of physicians and bias, disability bias, you can look at the adapresentations.org archives in the healthcare section, and you can see that. All right, let's turn to some questions that came up, and they'll be a little bit chronological, so we'll go back to the beginning. So Emily, these first ones will be from your part. For coordinating doctors or sending patients between hospitals, how do you handle patients not having coverage at that other hospital or with that other doctor?
Yeah, that's a fantastic question. Thank you for asking it. Part of the problem in equitable access to healthcare and our healthcare system overall is that our access is largely determined by our insurance policies in the country. And the cost of insurance is obviously differential and shaped by many, many factors, including employment, which is then in turn affected by people's race, migrability, and many other things that are discriminatory. So as it currently stands, there is no framework for establishing coverage and for coordinating without consideration of coverage between hospitals. And so what we saw happen in Boston during the pandemic, during the first peak of the pandemic, I should say, was that based on the goodwill of hospital administrators, individuals were transferred with costs covered, for example, or we picked patients who had an insurance system that was covered in both institutions, and those were the patients who were transferred over. What we need are coordination agreements that incentivize financially, because that's how hospitals work, that financially incentivize coordination between facilities. So Boston Medical Center, where I work, is the safety net hospital for our region, and we provide free care if needed for any patient who comes in. Our motto is exceptional care without exception, and we mean that without exception based on insurance or anything else. And so unfortunately, we don't have a system that exists yet to allow us to coordinate across facility lines without consideration of coverage. And what we need is one that at a minimum, makes exceptions for transfer and care of patients during times of crisis. These are things that could certainly be federally funded, covered by Medicare or Medicaid for transfer to compensate hospitals for taking transfer of patients who are otherwise unable to pay or otherwise uncovered. Yeah.
Great. Thank you. All right, next question is also for you. I'm going to group two of them together. People were interested in some of the processes that you described, and so they wanted to know if the SOFA scores on the QALY matrix are available to the patient and the family.
So I can certainly speak to the former. I will probably defer to Colin in terms of QALYs because it's just an area that I'm less familiar with at the policy level. But SOFA is a publicly available, published in the medical literature scoring system for predicting mortality from sepsis. So if you were to Google sequential organ failure assessment, you would turn up some of the papers that have developed and validated those scores. So those are certainly available publicly. QALY matrices, I'm actually less certain of where those are available.
So I can speak to that. The data is out there if you go looking for it, and it's not terribly easy to find or presented in a format that's all that intelligible. I should be clear that to this point, QALYs are not being used anywhere to make decisions about individual patients. That's a problem we're actively trying to get ahead of because we're worried it could go there. The proposals we've been fighting with regard to QALYs are more at the formulary level, right? where states or private insurers are suggesting that they use qualities to determine whether or not a treatment will be offered, will be available. So for instance, it was a very concerning case a number of years ago that disabled advocates fought back against, including us, where CVS Caremark was going to offer to the insurance companies it worked with as a pharmacy benefit manager that they could deny coverage for certain medications based on their quality score. So the sicker you, the more disabled you are, the less likely it would be that your medication would be covered by your insurance company, right? So that's the kind of thing we're really worried about. But in principle, there would be nothing to stop that kind of metric also being used in an individual case.
And we know that from the studies that Lisa Izoni has done and others, that physicians do inherently, even if unconsciously, incorporate considerations of quality of life in their decision-making about patient care.
Exactly. We often talk about quality logic, right, during the pandemic, especially. Yeah. Like even though qualities weren't being explicitly used, that same notion that people with disabilities had inherently lower quality of life and should be deprioritized for receiving care was rampant. It was just informal.
Okay, great. Next question. So actually, Colin, so on your suits or your actions, were they done under the ADA, or were they referencing the ADA, or how are you?
Yes. So I could say that the primary organization, and they deserve a ton of credit and support. I would urge people to check them out, to donate to them if you're able. The primary organization that was actually filing those complaints was an organization called the Center for Public Representation. They're based here in Massachusetts, but they're a nationwide organization. And so they would partner with, and they're a legal advocacy organization. We do legislative advocacy. So they would partner with local disability rights organizations to file either lawsuits or what are called OCR complaints, which are basically requests that the federal government intervene to stop a state policy. Then those state level organizations would join with them. So here in Massachusetts, had we ultimately had to file, it would have been a joint effort between them and us. And yes, the rationale for those was absolutely that those measures violated the ADA because the ADA requires that public services that services in general, right, be provided on a non-discriminatory basis, right? That a public or private entity cannot deny someone a service on the basis of their disability. And so our argument is healthcare treatment as a service, right? These are people being denied that treatment, or states proposing to deny people that treatment on the basis of their disability, and therefore the ADA is being violated. And by and large, federal regulators at the Office of Civil Rights fortunately agreed with that assessment and forced states to modify those policies. Okay,
and somebody just asked if you could put the link to that organization.
Yes, I'm getting that now.
Okay, great. And just to sort of clarify there, so there's two elements, right? There's the creator of the CSC who might be the state government. Is that correct?
Is always the state government, yes.
Right. So they have that ADA responsibility. The individual hospitals would also have a responsibility under the ADA or Section 504. Is that right?
Yes, absolutely. So for instance, the Hickson case in Texas, that hospital almost certainly, and that judge for that matter, almost certainly violated the ADA, right? That was, a clear-cut case of an audio recording of that doctor saying that this person should be denied this, that he should be taken off of ventilation and feeding because of his disability. Unfortunately, it's frequently the case that enforcement of federal law, right, enforcement at that level so rarely happens, right? Or at least it so rarely happens in those individual cases, right? Because the resources necessary for federal intervention are so limited, and often people's only recourse when discrimination occurs under federal law is to file a lawsuit, which is difficult, it's time-consuming, it's expensive. And that's why here we're really pushing hard for a state law, because that can be enforced by state agencies by local prosecutors, et cetera, who are considerably more numerous and able to, in practice, legislate those things. I mentioned earlier here in Massachusetts that there's no state law requiring that employee-only areas of workplaces be accessible. Of course, the ADA already requires that all areas of a commercial building be, a newly constructed commercial building be accessible. But we found that here, there's widespread instances of that happening anyway, because state building inspectors can only enforce state law. So it's a similar problem here.
Okay. Another question. Can you recommend a bias training curriculum?
That is an interesting one. So
it's a very interesting one.
There's actually very little out there. We're developing one ourselves because of the paucity of them in this space. So if you get in contact with me, we are presently waiting on hoping to get a grant from the Boston Foundation to roll this out. We have one that we use for our own employees and that we've taught to high school students and to community organizers. National Council for Independent Living does have some resources. If you look at their website, the Disability Rights Education and Defense Fund, DREDF, has some good articles on this. But in terms of a systematic curriculum, there unfortunately isn't a lot out there. So watch this space. And once we have something up and running, I will absolutely loop back with the ADA Center to help get the word out.
Yeah, specific to within healthcare, again, there's very little that is evidence-based, and there are a lot of people, myself included, who are working on teaching physicians about bias. My focus is more on racial bias, although disability rates also come into my work as well. There is a resource library that contains some resources within the Society for Academic Emergency Medicine. I can put the link in the chat there. The Academy for Diversity, Inclusion, and Equity within Medicine consolidated resources from elsewhere and has those posted. I believe that's all publicly available as sort of an example.
And I will say, if anyone listening is from a hospital or a health system and would want this kind of training, please do get in touch. It is something that we could develop and work with you on.
Absolutely.
And I will also put in a plug for the fact that all of your regional ADA centers would be able to provide this kind of training in an ADA context, because almost every training that we do has a disability awareness segment, which is basically a similar kind of a focus. So you certainly can contact your regional ADA centers for help with that. All right, let's see what else we've got. Do EMTs and other first responders also utilize these biased metrics when deciding on site of a disaster, who to take back to a hospital and who to leave, or their CSC for them?
That's another great question. So there are there are first responder triage tools that are designed to help categorize patients according to who is most likely to be saved. Those, at least the ones that I have seen, the ones with which I'm familiar, are very focused on immediate survivability without consideration of longer term survivability. And while there are different metrics for pediatric injuries and adult injuries, I have not seen, it's not an area that I thought deeply about. So I'm sure that there are ways in which they are biased, but they are more focused on the imminent survival of people injured at a disaster scene.
Okay, next question. What are the chances of getting medical school and other provider training altered in the long term to include training on disability implicit bias as part of a response to what we have seen with COVID-19's impact on people with disabilities? What would be needed to get that change?
That's a great question, Sylvia. Thank you so much for asking it. So the answer is very likely that these are going to be changed, that medical education and other provider training for clinicians, it is changing right now. Many of the areas that we have been focused on specifically addressing relate to racial bias in medicine and the ways in which racism is perpetuated um, and really just entrenched in medicine and medical education. Everything from, what color are the simulation mannequins' skins to how do we learn about dermatologic skin diseases and on whose skin do we see pictures of those in our tests and our textbooks, and thoughts about biologic racism, like supposed inherent differences between how people's organs work or other traits that historically we've been taught track with race, which in fact do not. The curricula that are being developed to talk about bias absolutely do include, and sort of the conversations I have and the sessions I lead on thinking about bias, unconscious and otherwise, incorporate information that is meant to address unconscious bias against people with disabilities and ableism in general. There's certainly work within this space, but it's something that has to change at the local level, at the institution level, and at the level of each of our schools and our testing centers. Med schools teach the test, and so if there are questions that we are required to learn in order to pass the tests, I think that can be a powerful driver of change. So some of the organizations that create board certification exams and medical school entrance exams or medical school graduation exams, the USMLE, the medical licensing examinations, for example, are places where we can pull levers to drive change. There's certainly a generationality to it, though. There's the folks who are coming through medical school now are talking about microaggressions and unconscious bias in a way that, I'm not that old. I graduated medical school in 2013, and we didn't talk about it at all when I was going through training less than 10 years ago. So things are changing rapidly in this space, and it gives me hope for the future.
Yeah, I think just to add briefly to that, because I think you spoke to it very well. A big part of this is getting more people with disabilities into medical schools, right? I think that people with disabilities, disability bias will be fought fairly effectively if folks have disabled peers who are themselves doctors. But there are substantial barriers to disabled folks in medicine, including, as you pointed out, some of the entrance requirements, some of the requirements for sort of tests or professional standards that for which accommodations aren't allowed. And then I'd point folks towards the work of Sherry Blowett, CHERIBLAUWET, who is one of the most prominent wheelchair-using physicians in the country, is both a practicing physician and a professor of medicine at Harvard Medical School. And this has been a major cause for her, is helping to get more people with disabilities into the medical profession. But yes, this kind of training is clearly needed. It's also that I think more doctors need to spend time, in terms of clinical rotations and that sort of thing, doing work in rehabilitation, as a medical specialty. One thing that showed up in the work of Dr. Iazoni and others is that rates of this bias are much lower among rehabilitation physicians than they are among, say, emergency room physicians, because they're the ones who actually spend more time with people with disabilities, get them to know them more as individuals, and see ways in which people with disabilities having lower quality, apparent lower quality of life actually has less to do with their biology than with lack of access to accommodations. So that's another critical piece of the puzzle.
I wholeheartedly agree with that, Colin. One of my co-residents, unfortunately, I had a spinal cord injury while he was a resident. And the process of having him come back to complete his residency training as a wheelchair user was incredibly educational for our program, for our institution, for the physicians who worked with him, for everybody who worked with him, and was transformative in the institutional sort of capability for supporting people with disabilities, not just people who have physical disabilities, but others as well. And so it really changed the perspective of program leadership. We can't answer everything with representation and diversity of ability, but that is a huge component for sure. And if you aren't exposed to it, then it's very challenging to learn that. I think in the same way that if you grow up in a very racially segregated area, it's hard to unlearn the things you are taught. If you have no exposure as a physician to caring for people with disabilities, it's, it's understandably difficult to appreciate the ways in which their care should differ from the ways in which we care for other patients. So there's absolutely an exposure piece that is critical to moving this forward.
All right, and one last set of questions here that before we close. Coming back to the crisis standards of care, so how would you recommend for anybody who's listening for them to monitor these, or to object to them, or raise concerns about them, or how would you recommend people take steps here?
I can start with that. So I think a couple of things, right? Talk to your legislators, right? Get them involved in this kind of thing. Encourage them to take steps legally. Work with your local disability rights organization. Ask them if they're working on these issues. Press coverage is huge, right? Even politicians who don't care very much about the impact of an individual constituent will care very deeply about a bad, a news story that makes them look bad, right? And journalists are interested in these kinds of stories often. So that was a hugely effective tool for us. And then one of the key things is whenever these things are being considered, right, there need to be people with disabilities on the committees writing the regulations, right? So if you see these kind of thing going on, ask that question immediately and repeatedly and loudly until they actually agree to put somebody on the committee, because it was only when I and others got on the committee here that something changed.
Yeah, I completely agree. I mean, the power of public shaming through the press is unparalleled for moving policy. And again, we all have blind spots, and the group of largely white male able-bodied physicians who are in charge of healthcare systems across the country have big blind spots, and it's not through any malice, generally speaking. They're just simply not exposed to the issues. And no one at the table who wrote the initial crisis standards of care for Massachusetts thought about the ways in which a Glasgow Coma score could be discriminatory. It just never occurred to anybody. And so it's absolutely critical that we have representation there. But if you're interested in pursuing this further at your local level, each institution will likely have its own guidance. Whether or not that's public will depend from one place to another. The state level guidelines are widely available, and there's a paper in here that I wrote over the summer comparing crisis standards of care between states, the appendix to which has a link for each of the available guidelines. I can't promise that those are all still live, because obviously web links change frequently, but the state guidelines as of the summer were available in there, so you can review them. And then you can also look to some of the folks who have written about this issue, both from a disability rights perspective and more broadly about crisis standards of care in the medical literature. There are people who also have sort of the ear of policymakers and may be able to point you to guidance for who to speak with.
All right. Well, we realize that many of you may still have questions for our speakers, and apologize if you did not get a chance to ask your questions. If the question is an ADA related question, you can contact your regional ADA center at 1-800-949-4232. If you wanted to talk to Emily or Colin, their contact information is there on the screen for email, or it looks like maybe Twitter, huh? Thank you very much for that. All of you will receive an email with a link to an online session evaluation. Please complete that evaluation for today's program, as we really value your input. We want to demonstrate its value to our funder. We want to thank Emily and Colin today for sharing their time and knowledge with us. It was a very interesting presentation. A reminder that today's session was recorded, and it will be available for viewing next week at adapresentations.org in the archive section of the healthcare section. So watch your email 2 weeks ahead of time for the announcement of the opening of our registration of our next webinar. And thank you all for attending today's session, and have a great rest of your afternoon. Thanks again, Emily and Colin.
Thank you so much.
Thank you.